presentation. Glad to see many faces of older and recent colleagues, and hope to talk to them after the end of the first session. So what I'm going to do is to take you into a small ride in the 2023 update of the Saudi osteoporosis guidelines. I'm proud to say that I have no disclosures related to this presentation, although I was on the board and advisory boards of several pharmaceutical companies, but there is no relation to this presentation. I'm proud to say that we're the first country in the Gulf region to publish guidelines for osteoporosis. I cannot say in the Middle East, because in the Middle East, Ghada Al-Haj and her group in Lebanon published their guidelines ahead of us. But this was a very comprehensive paper, well written, well cited, and published in 2015 in the Annals of Saudi Medicine, with the contribution of colleagues from different disciplines, different institutions, and specializations from all over the kingdom. So it was published in 2015, and in 2020, we said it's enough time, after 7 years, to try to update these guidelines. And the Saudi Osteoporosis Society formulated a task force, included the members written in the slide. And those members were from different disciplines again and institutions: National Guard Health Affairs, King Faisal, King Saud University, Dr. Hazim from Advanced Medical Center, Ministry of Health, of course, and many other organizations. These guidelines were endorsed by the Ministry of Health, the Saudi Rheumatology Society, and we have a member on the Saudi Osteoporosis Board, who is the president of the society currently. Saudi Health Council is awaiting till now, and this is maybe a reminder to our colleague in the administration of SOS to get their approval, our endorsement. And it has been endorsed by the Committee of National Societies of the International Osteoporosis Foundation. So this is just to say that we emphasize in our guidelines postmenopausal women, so it did not touch on osteoporosis in men. And we also mentioned many aspects that I cannot cover in the talk, so it's just an outline, and my colleagues in different presentation will cover more aspects. We depended mainly on the important guidelines that my colleague and the previous speaker mentioned about, mainly the American Association of Clinical Endocrinology, the new name for them in 2020, and the European guidance published in 2019, and the GCC consensus report, which was published in 2020 in collaboration with European Society for Clinic and Economic Aspect of Osteoporosis and Osteoarthritis. So the outline of my talk, just a touch on screening, diagnosis, the fracture risk assessment, the intervention threshold, and management, and then I will conclude by a summary. So whom to screen? You're going to have a full presentation on whom to screen by one of our colleagues in the next sessions. But we mentioned in our guidelines that the International Society for Clinical Densitometry and the American Association of Clinical Endocrinologists advocate universal bone screening for women above 65 years of age. So in the state, anyone less than 65 will not be screened unless there are risk factors, otherwise the insurance will not cover it. All, if they have fragility fracture or is receiving osteoporosis medications or is going to receive these medications. In our previous guidelines in 2015, we put the age of 60 based on experts' opinion. But the approach in 2023 guidelines is different. And just to say that in Kuwait, for example, they recommended screening for every men and women above 50 years of age. And we think that's a very young age group to screen for osteoporosis. And they have that if they have a fragility fracture or FRAX score between the upper and lower assessment threshold. We mentioned in our 2023 update that the best way to do this is to cut the limit of 65, or below that, you try to do the approach adopted by the National Osteoporosis Guideline Group in 2008, and this is by case finding strategy. So a patient steps in the clinic, you sit with the patient, get the clinical risk factor that she has, do FRAX. This is before doing a BMD. We didn't reach the stage of BMD yet. And based on the score of the FRAX without BMD, 3 categories: low, you advise on lifestyle factors, and high, treat. And if the patient is at intermediate risk, this is the group that you'll go ahead and do bone mineral density. After you do the bone mineral density, do FRAX again. So refrax the patient and decide if the patient is low or high risk. So this approach is probably the best to save resources and to select high-risk patients to screen them. What about diagnosis? We adopt the same international community cut limits, minus 2.5, to diagnose osteoporosis. Below that is osteopenia, and above that is osteoporosis. But we mentioned clearly in the guidelines, and this is to stress what my colleagues has mentioned, this is a diagnostic and not a therapeutic cut limit. So what we commonly see in the clinic is somebody who comes in with a T-score of minus 2.7, and she is 45 or 55, a young patient with no other risk factors. And these patients, when you FRAX them, do fracture risk assessment online, you get a small or low readings, and these patients do not deserve to be treated even with that T-score, of course, after you rule out secondary causes for the low T-score. Some people use the ultrasound scan, and this is done in campaigns, for example, where some of the pharma companies used to have these machines, and these modalities are not approved because they lack standardization, and confirmatory DICSA has to be done if the finding on them is low. So you cannot diagnose osteoporosis except by doing bone mineral density or DICSA scanning. This is one reason why we say that minus 2.5 is not a cut limit to treat every patient, because fracture risk is so variable across the world, and we lie in the lower green countries where the fracture rate in our country is much lower than the other areas in the world, like high-risk countries in the red. And minus 2.5 in somebody who's 60, 50, 60, 70, 80 has different risk for fractures. So age is very important, risk factors is very important, and that's why we always say do FRAX and see. Even with that low T-score, the patient might not deserve treatment, especially young people. What are the secondary causes for osteoporosis? And this is very important. You need to rule out secondary causes that caused the patient to have fracture or low T-score. And this is a list of some of the secondary causes that you need to ask about when you interview your patient in the clinic. Ask about endocrine diseases. And mainly one of the major causes that we found nowadays is hyperparathyroidism, even with normal calcium. So high PTH, normal vitamin D, normal calcium, what we call is normocalcemic hyperparathyroidism, one of the major causes now that I see personally in the clinic and diagnose frequently as a cause of osteoporosis. But also diabetes is a risk factor for osteoporosis, eating disorders, growth hormone deficiency, acromegaly, Cushing. Gastrointestinal diseases, especially malabsorption, are very important. Hematological disorders, autoimmune diseases, renal disorders. So any reduction in GFR makes the patient likely to have osteoporosis or renal bone disease. And last but not least, very important, medications. You have to take a full medication history, because proton pump inhibitors, for example, steroid with all forms, whether topical, ointment, IM, oral steroids, are very important cause for osteoporosis. And I've seen, personally speaking, in the clinic, several patients who are using steroid creams for years, and they become osteoporotic. Early menopause, those who has Sheehan syndrome and stop periods at young age. So very, very important when the patient steps in the clinic that you take a full history and not only seeing the T-score and starting treatment. This is a list of some of the investigations that you need to do. And again, there are essential investigations like the complete blood count, ESR, calcium phosphate, alkaline phosphatase, parathyroid hormone, and vitamin D. And if you think of malabsorption, you do the screening for celiac disease, 24-hour urine calcium. Some people cite it as a major investigation when you do not find a reason for the patient osteoporosis. So investigations are very important. In the DEXA scan, there is something called trabecular bone score, and this score can be put on the, or you can get it from the scanner, and it adds to the precision of the definition of the osteoporosis by bone mineral density. And there are some examples for it. Maybe my next speakers will touch on it. Vertebral fracture assessment, looking at the spine. And again, this is a software in DEXA where it will show you the vertebral bodies in this fashion. So some patients have silent vertebral fractures. And very important, if you don't do this, to do lateral DEXA X-ray of the spine for your patient to look for these vertebral collapses, because once they are present, the patient needs treatment irrespective of his or her T-score value. So this is T12 wedge fracture, anterior wedging, which is typical for osteoporotic fractures. There are limitations for BMD, which is the low sensitivity. You need to lose a lot of bone density before it appears as a low T-score on DEXA. It doesn't explain the heterogeneity of fracture risk worldwide. So the same T-score, as I showed in the previous slides, has a different fracture risk in different countries. Minus 2.7 in the kingdom is different from that from Scandinavian countries or United States or other high risk for fracture countries. Different ages, and I mentioned that point. There are sound reasons to conclude that diagnostic threshold based on BM are not optimal as intervention threshold. Just confirming what I've said, that do not treat based on T-score alone unless it's very low. Fractures are very common in osteopenic patients, and this is from NORA study, the National Osteoporosis Risk Assessment, more than 200,000 women in the United States. And when they looked at those with fractures, many of them are osteopenic. They are not osteoporotic. But if you have osteoporosis at the tail of the curve, the lower the T-score, the percentage of fractures becomes higher. So T-score or very low T-score is very important. But number-wise, more fractures happen in osteopenic. And that's why people looked for other risk factors and come up with what is called fracture risk assessment. So these are important risk factors that has been validated in large studies, large population data, and they found that these are the most important factors. And nowadays there is something called FRAX Plus, which is an update of FRAX where they added more risk factors or make these risk factors more specific to make the FRAX assessment better performing. So age, the 6, weight, height, that means the body mass index, smoking history, alcohol, prior fractures, parental hip fracture, a father or mother with hip fracture, secondary causes, the list that I showed you, and steroid use and rheumatoid arthritis. These are the most important risk factors. If you print FRAX in Google and then press on Sheffield University web page, this page will appear, and this is John Canis, the father of FRAX. And if you go to calculation tool, Middle East and Africa, press that button and you have the countries in the Middle East. And as has been mentioned previously, Saudi Arabia joined the FRAX in October 2021. So this is Saudi FRAX. You enter the age of the patient, the 6, and the height and weight, and then ask for risk factors. If the T-score is done, you add the T-score or the bone mineral content, press calculate, and it tells you the 10 years probability of major osteoporotic fracture and hip fractures. And based on that, you treat your patient or you defer treatment. So this is the web page, the sheffield.ac.uk, or simply write FRAX in Google and it will appear. So in the GCC countries, you have Saudi Arabia, United Arab Emirates, Abu Dhabi actually, Kuwait, Oman, Qatar, and also Lebanon and the Middle East, Jordan and Palestine. This is our publication where we looked or tried to measure our FRAX performance and joined the community in October 21. And sincere thanks to all colleagues who participated to carry on or calculate or pick up patients with hip fractures across the kingdom. And from the WHO working group, John Canis and his group, Eugene McCloskey, Helena Johansson, and other colleagues, Ministry of Health, and at the bottom, at the back of the page, the Saudi FRAX group, study group, conclude many colleagues in different hospitals who played a major role to give us the patients admitted with hip fractures in their respective hospitals. This is the FRAX, Saudi FRAX compared to other countries in GCC, and it's almost comparable to Kuwait and Abu Dhabi and Qatar. There's no much difference. Abu Dhabi, they have in red, have this drop after the age of 80 because of increased mortality after that age group for different reasons. This is a table that is put in the guidelines 2023 update, and these are the intervention threshold that you use according to the age group, so the age on the left side, and then the intervention threshold for major osteoporotic fracture and hip fractures. If the patient has a fracture, you don't need to do all of this. So simple fracture, somebody who is walking and fell down and break a vertebrae or a hip, this is a patient that needs to be treated. So low trauma fracture is an indication to treat, and this is what is mentioning in this next slide. So patient with fragility fracture, you need to treat them. T-score, which is low, some people say above 2.8, some others say above 3. That patient needs to be treated after ruling out secondary causes. All the others use FRAX on your patient, and I teach the fellows when I use them to work in National Guard that do not come and discuss a patient with me with osteoporosis unless you do FRAX, and then come to the clinic and give me the reading. So low T-score again and again, less than minus 2.5 is not an indication to treat in the absence of risk factors. Let me give you an example of FRAX. So a patient came in the clinic who was 65 years old with a T-score of minus 2.5, positive family history of fracture, and you take a history, no piece of fracture. One of the parents had a hip fracture, so we pressed there yes. And no steroid, no rheumatoid arthritis, no secondary causes, no alcohol, and the physical exam BMI 2.4, and the BMD is osteoporotic, minus 2.5. So this is a patient with definition of osteoporosis as per DICSA definition, and family history of fracture. What is the Saudi FRAX says? Major osteoporosis is 11, and hip fracture is 2. This is a quite high-risk patient, and you need to give her treatment based on the finding with a T-score of minus 2.5 at the age of 65. I have the same patient. When you change the age to 50 or 55, the scores becomes low, and the patient does not need treatment, even the T-score is minus 2.5. So very important to stress that. These pictures, my colleagues talked about them. When you do FRAX, you need to put the patient in either of the 3 categories, either in red area. This is a very high-risk patient. You give anabolic. Green area, patient is low risk. Advise on sun exposure, calcium, and vitamin D intake. And then the patient below what is called intervention threshold. This is again a low-risk patient, and then above the intervention threshold, you do BMD and you refrax the patient. A bit complicated, but if you read the paper, it might become very clear to you. Very important to take steps to improve the lifestyle of the patient, vitamin D and calcium. And mind you, before instead of entering into deeply into this huge issue of vitamin D and calcium, that we have in Saudi Arabia consensus report on vitamin D. So please refer to this patient, which is called Vitamin D Status Correction in Saudi Arabia, an expert consensus under the auspices of the European Society of Clinical and Economic Aspects of Osteoporosis, osteoarthritis and musculoskeletal disease. This is published in 2017 after we performed a 2-day symposium in the kingdom on vitamin D. And also we published the GCC vitamin D consensus report This paper involved colleagues from all over the Gulf Cooperation Council countries, and this was published in 2020. So please refer to them. I'm not going to speak about the medications, anti-resorptive, and these are the doses and duration. These are put in 2023 update of the Saudi osteoporosis guidelines, and these are the agents approved in the Kingdom of Saudi Arabia. We put in the guidelines a table that mentioned the category of the drugs and first-line therapy and alternative first-line therapy. There is a first-line therapy for every patient that sits in front of you. So there is no one medication that fits all. Every patient can be treated by a different agent. So you need to choose the proper medication for the proper patient. This table also is there in the guidelines, and it summarizes everything: the diagnosis, fracture risk assessment, supportive treatment, risk factors, additional information, and then on the right side, the pharmacological treatment, intervention threshold, and the follow-up of the patient. When do you repeat DEXA? Some people do it in 6 months, 7, 8 months. The better in 2 years, 1.5 is fine, and the minimum is 1 year to find changes in the T-score. Below that, it's not needed at all. It's just a waste of resources. So in a summary of the key recommendation, these are the last slides for me before I stop. Diagnosis, T-score of minus 2.5, but not the last line in the slide. This is a diagnostic and not a therapeutic threshold. And presence of low trauma fracture is diagnostic and deserve to be treatment, irrespective of the BMD finding. Osteopenia is not a disease. We see some people who give osteoporosis medication for patients with osteopenia, and this is not proper. This is a risk factor. You need to look for other risk factors, do FRAX, and if the patient score is high, then this is when you treat osteopenic patients. Otherwise, it needs just observation, calcium, vitamin D. Fracture risk assessment, as I mentioned in the slides, is very important, and this has been highlighted in the updated guidelines. And you calculate in the beginning without DEXA. If the patient is the intermediate risk, then you go and do a bone mineral density. High risk on FRAX, you can treat even without BMD. You prefer BMD to follow up the response to treatment. Otherwise, 70 years with fracture or with high FRAX scores can be treated without BMD. Trabecular bone score might help BMD measurement, as I mentioned. And vertebral fracture assessment need to be done on every patient. If not there on DEXA, do a lateral X-ray spine to look for silent morphometric fracture. Peripheral ultrasound are not for diagnostic purposes, just maybe for screening, and their need now is much low. You counsel the patient to risk factors. Calcium, vitamin D are very important. We have some papers on the proper timing for sun exposure in the kingdom in different regions. Please refer to them. And they are also mentioned in the consensus report that we published in 2017 and mentioned in the GCC vitamin D consensus report we published, as I showed you, in 2020. Treatment, again, as I mentioned, stress the fact, and the majority of patients, oral bisphosphonate are there, but denosumab and anabolic can be first-line treatment for many other patients based on the risk, on their fracture risk, and the severity of the fracture, the multiplicity of fracture, and different reasons. So as I mentioned, there is no treatment that fits all patients. You need to select the therapy based on the characteristic of the patient that is sitting in front of you. In the guidelines, we mentioned on sequential treatment, when to stop which and to carry on with which. Mainly anabolic first for high-risk patient, and then you follow the response of anabolic therapy, 2 years with teriparatide, 1 year with romosozumab, with anti-resorptive to preserve the gain in density that you achieved with anabolic agent. Drug holiday also has been touched on in the update. In the update, we mentioned about monitoring of therapy. The fracture lesion service has been also advocated, and when to do a BMD, as I mentioned, 1 to 2 years, preferably 2 years, minimum 1 year, and not before that. These guidelines is whether the first one in 2015 and the update in 2023 is a result of a hard work and dedication from various colleagues, either in the society or from outside the society. I'm very thankful to them, and we hope that to carry on to do more work, especially on the FRAX aspect. Our paper published in 2021. We believe that is not the best. It's the best that we can do at this time, but we need to have some way to collect fractures, whether they are hip or vertebral fractures, to more precise our FRAX record or score and get more benefit to our patients. Thank you very much for your attention.